Welcome to this medicine masterclass in which we will be discussing venous thromboembolic disease and particularly focusing on the likelihood of recurrence following a primary event. Once a patient has had a blood clot, one of the key concerns they have is whether or not they will have another event. There are certain risk factors. An idiopathic, unprovoked presentation increases the risk of recurrence, as does thrombophilia, cancer, the presence of residual thrombus mass, whether the DVT was proximal, as well as increasing age and the male gender. Moreover, a shorter duration of oral anticoagulant therapy has also been associated with increasing the risk of recurrence. VTE recurrence is higher in unprovoked episodes. Patients with no major clinical risk factor for venous thromboembolism, such as the absence of surgery, trauma, immobility, the absence of pregnancy, without using any drugs such as the oral contraceptive pill, or thrombophilias, have a higher recurrence rate. In patients with an antecedent, as well as a transient major clinical risk factor, the risk of recurrence is reduced. Randomized controlled trials studied the NOACs to see whether extended therapy could reduce the risk of VTE. The Amplify extension trial studied the extended use of apixaban, the Resonate trial studied dabigatran, the Einstein extension studied rivaroxaban, and the Remedy trial studied dabigatran. These trials demonstrated that with prolonged usage of the NOACs, the risk of recurrence was reduced. In the Amplify extension studies, patients were randomized as either placebo, apixaban 2.5 mg BD, or apixaban 5 mg BD. What was found is, irrespective of the dose, the recurrent risk of VTE or all-cause death was reduced in patients on 2.5 and 5 mg BD, whereas the risk of major bleeding, which was the primary safety endpoint, and the major risk of clinically relevant or major bleeding was the same in both placebo and in the apixaban group. As a consequence, the NOAC drugs are now used in certain groups where recurrence risk is deemed high for beyond a period of 6 months. Here is a summary slide of how patients are treated. If VT is confirmed, a patient is started on apixaban 10 mg BD for 7 days and subsequently switched to 5 mg BD for a period of 3 to 6 months. Following this, a clinical review is undertaken, and if there's a higher risk of recurrence, 2.5 mg BD can be prescribed thereafter. Dabigatran is first, the patient is treated with parenteral anticoagulation for at least 5 days alone, and subsequently 150 mg BD of dabigatran is started. Rivaroxaban does not require parenteral anticoagulation, 15 mg BD for 21 days, followed by 20 mg once a day with food. Subsequently, the Einstein Choice trial allows the patient to be reduced to 10 mg after an initial anticoagulant period. Thank you for attending this medicine masterclass.